Hello, everybody. I'm Cliff Megerian, and I'm the president of University Hospitals Health Systems. I'm joined by my colleague, Dr. Beck, who I'll introduce in just a second. First, I'd like to thank you and apologize a little bit for the technical glitch that we had in terms of getting out the fairly new number that we needed as a password. And so the good news is now we got pretty much everyone online. So I think we'll be able to proceed forward. First, I want to thank all of you, all the donors, the supporters, the UH family for taking the time out to spend a little bit with us as we discuss some of the forward progress that we're making. I'm going to be joined today by Dr. Eric Beck, who's the Chief Operating Officer, and together, all of us have been working very hard, as you know, in responding to the COVID situation, but more importantly, over the last few days, responding to the reemergence or rebirth, if you will, of the UH clinical activity. But before we get started, I'd like to play, I think, a video that you will enjoy. This is part of our strategy, is to create a series of public service announcements, marketing touch points, both digitally and in other venues, to really give the following message to our patients and our community. Number one, that per the governor's orders, it is now okay to seek non-essential procedures. And number two, as of today, it is okay and within the rules, if you will, to pursue office visits. And although that's been said by the governor, we want to be abundantly clear that we believe there's a couple things that our patients and you want to know. Number one, our doctors, do they want you and do they think it's medically necessary for you to come back? And we believe it is. And number two, our research shows that the fundamental issue in the minds of our patients is it safe and is it clean? So with that being said, I'd like to show a video that's being circulated by Dr. Kathy Sila that represents our thoughts. So if we can roll that video, Kim, that'd be great.
Thank you. You stayed home. You flattened the curve so hospitals weren't overwhelmed. You took care of us. Now it's time for us to get back to taking care of you. University Hospitals is following CDC guidelines and all of the governor's recommendations to ensure your safety. Your healthcare needs haven't gone away, and there's a risk to ignoring them. We are here to safely provide you with the care you need.
Thank you. That's just part of the overall strategy of getting the message out that not only is important and timely for us to re-engage with our patients, but our patients to re-engage with us. I'd like to ask and turn it over for some brief opening statements from Dr. Beck in terms of our strategy of, if you will, the re-energization of the organization, the rebirth, regrowth, and reopening, if you will, and what are some of the strategies we're doing. And then we'll open it up to your questions, because I'm sure there's a lot with some of the news about remdesivir. So, Dr. Beck?
Good morning, everyone. Pleasure to be with you. And let me too begin by saying thank you for joining us today. Thank you for your support to UH during this time. Without you, we would not have been as successful as we have been to date. And certainly each of you in your own ways have helped us as a region and as a state to flatten the curve. So with that, happy to report we're well on our way to resuming full services. We've started by focusing on those patients who had canceled procedures or had to postpone their procedures. We focused on those patients who have particularly important health needs, those with chronic conditions, those that are more vulnerable. And while we've been in touch with them during this entire time through virtual channels, video visits, telephonic encounters, and in many cases still visiting in person in the physician's office, in our clinics, and in some cases in the hospital, we're really excited to be able to help people get the care that they need. And as you heard so elegantly from Dr. Sila, it's really about engaging in a conversation with each other and with our community around how to put the risk in context. The risk now is really for those folks who have needs, clinical needs, healthcare needs, who are going without the services and support that they need. So that's really the focus of our conversation. As of this morning, we're doing hundreds of surgeries and procedures across the system. Patients go through a COVID testing algorithm on the front end of getting those procedures scheduled. So there's additional precautions being taken. And as you've heard, we're going to great lengths around how we engineer those encounters, those visits, those procedures, whether they be outpatient doctor's offices, well baby checks, getting a needed mammogram, et cetera. All of those come with new protocols around how you check in from your car, how you can expect to have a touchless experience or as close to a touchless experience as possible, physical distancing in our waiting rooms, et cetera. So off to a great start, and look to you to help us continue that conversation with friends, family, and the community as we begin to meet the needs of our community.
Let's open it up to questions.
Sure.
And let's just start with an overall question about what patients can expect when they walk through the doors of UH moving forward. How are things different now well, we're still in the middle of COVID-19, but after everything that we've learned from COVID-19?
Well, I'll go ahead and start. The first is that as has been the protocol, we're screening anyone who comes to our front doors. That includes questions, taking a temperature. It includes masking. While I'm not wearing a mask and Cliff is not wearing a mask at the moment, we were just prior to this video telecast beginning. So masking is a really important strategy. And as you've heard, it keeps everyone safe. So that's the first piece. The second piece is really engaging in a different waiting room experience. And that waiting room experience includes trying to keep things as touchless as possible, trying to space apart any chairs or surfaces that a patient or a visitor may interact with, and then frequent disinfection. So cleaning those surfaces around the clock, additional staff investing in that particular exercise. There's also some physical barriers and dividers, plexiglass, for example, between members of our support staff and patients where that's appropriate, and then spacing out a number of people in the office to try to maintain physical distancing as much as possible. We continue to offer virtual channels where that makes sense, but again, many people require in-person encounters for physical exams, certain diagnostic studies, and certainly for needed procedures and services.
We are starting to get questions from our participants. So let's start with a question from Shannon wanting you to use your crystal ball and talk about the activities. And these are important activities. We're not talking about just getting out for vacation, but weddings at the end of July. Is it still too soon to figure out how things are going to be then?
I'll start. I think that the good news is for us as healthcare industry, we don't need a crystal ball. We've now been given the license to begin to open up some sense of normalcy with regards to how we engage with our patients and how the patients engage with us. But I think what we have to remember, as outlined by Dr. Beck, I think the government and the governor feels very, very confident of opening up this segment of the economy because us as doctors and nurses and healthcare professionals, he knows he can count on us to have proper masking, social distancing, hand washing at all of our interactions with our patients and with each other. I think that my crystal ball doesn't go deep enough to tell me whether or not a wedding, for example, that's scheduled in August, or a backyard graduation party that's scheduled in July, whether or not the governor and Amy Acton, our health administrator for the state, will feel that level of confidence yet about opening that up, because I think a little bit more time needs to be taken to see how some of the, if you will, businesses that are given a little bit of license to open, how they respond, and more importantly, how the toll of maybe new virus cases results from. I think we just have to see how that works. I'm very confident that the hospitals, the doctors' offices, will be able to use all the necessary and available strategies to make sure that as we slowly open, that we don't spread the disease. I can't guarantee it, but I'm confident we can do it based on the knowledge that we have. But I don't know yet how that's going to fly, if you will, in the private arenas of weddings and so forth. I think we have to see how May works with regards to new cases. And from there, I think we'd be able to better predict what the governor would do.
So now it's been 6 weeks at least. We're talking about taking care of patients with illnesses that are not related to the virus. So what has changed that we're now able to do that? There's some people who would indicate that there was an overreaction in the beginning. Could you speak to what we know now versus when this started?
I'm happy to start. So what we know now is that, in fact, weeks and now almost 2 months have gone by, and we know that we're not seeing the numbers originally projected. And if we really look forward, it's really about how we understand the expression of the pandemic in Ohio, and in particular in Northeast Ohio. And right now, that expression is really focused on high-risk and vulnerable populations, particularly in dense housing or living arrangements. Those include skilled nursing facilities, group homes, congregate living environments, prisons, correctional facilities, et cetera. And so as a response to that, UH has been leading a statewide initiative to send resources out to those sites, to test those populations, to provide PPE when that's necessary, to really support a test and treat in place. What that's done is it's really helped us preserve our hospital capacity, preserve PPE. All the while, UH and our partners here in the state have all been ramping up testing capacity. As we've ramped the testing capacity, we're now able to better understand the prevalence of the disease and better able to manage the risk. As I mentioned, for example, with COVID testing being performed on patients before they have a procedure, for example. So I think that's really the fundamental change, is that thanks to you and all of our neighbors here, we've had an opportunity to buy time, build testing capacity, understand the expression of the pandemic in a very different way than originally projected, and to concentrate efforts there. And as Cliff mentioned, probably too early for us to predict the future, but I think we're all optimistic that with continued prudence, good judgment, we're going to be able to hopefully continue to enjoy something less severe.
I may add one thing, and I think this goes along with what Dr. Beck was saying. And the question was about what do we know now that we didn't know on March 15th when we canceled all non-essential procedures, when we really dissuaded people from coming in to see the doctor. I think the big difference between then and now is that then, in March 15th, we had actuarial models that was suggesting that we would have up to 5,100 COVID patients in the University Hospital's health system. That's 3.3 times our normal capacity of patients. And as it turned out, we have anywhere from 60 to 70 patients, not 5,000. And when it looked like we may have 5,000 based on those models, I think it was not unreasonable to preserve PPE, masks, gowns, and gloves, and other things like ventilators and ECMO machines for that deluge of patients that was thought to be coming in. Once it became abundantly clear that that was not going to happen, at least here in Ohio and at university hospitals, unfortunately many of the hospitals in Ohio, that it was not going to happen to that level, I think the leadership of our state and with consultation with us, who worked with the governor, he became comfortable with the idea of opening back up the so-called non-essential procedures, et cetera, and didn't mind using PPE for that purpose because we're just not going to see that deluge, if you will, of patients. So that was a good thing.
So let's talk about what we know now. After we've done this social distancing, masks are going to be expected. A lot of people haven't been outside their homes though. So as we start to live again, a lot of kids wanting to do babysitting, they're wanting to get jobs. How can we do this safely, bringing people back together again?
Well, we feel that we are a valuable partner in terms of giving some necessary advice to many of our businesses and friends in the community. So we're standing up a team led by Joan Zeltansky who will be putting together what's called a playbook. That playbook will describe our opinion that's based on CDC guidelines, governor's guidelines, Ohio Department of Health guidelines, what should be the behaviors of organizations, companies, small businesses in making sure they follow the guidelines. And we're putting that together, and maybe I'll turn it over to Eric to describe how people can get a hold of such material as we are working on it to advise. Not that we're the final authority, but we believe as a partner to you and our community, including some of the companies that have reached out to us, large companies, we're helping guide them. But it all boils down to very straightforward things. So I'll turn it over to Eric to embellish this a little bit more.
Yeah, well, thanks, Cliff. Again, you'll hear more from us in the coming days regarding the playbook, how you can access that, some of that more relevant to small businesses, others to larger organizations, and then much of it is able to be applied in your everyday activities as a household, as a family unit, with friends, etc. But let's not forget the basics. The basics and the foundational pieces are really what keep us all safe. And that all begins first and foremost with good hand hygiene. So continuing to wash our hands, being mindful not to touch our face and mouth, and keeping surfaces clean. Secondarily, wearing masks in accordance with the order from Governor DeWine, trying to limit large gatherings to the smallest number of people required. But also taking advantage of distance. And some of the best places to do that are outdoors when that makes sense. Certainly the weather is starting to favor such activities. So don't forget the basics. They really are where all of the science is rooted in helping to minimize the risk and minimize the spread. And as Cliff said, we have a channel that'll be available through our website for you to ask an expert with specific questions. And that'll be coming out here in the next couple of days. So we look forward to supporting you in that way as we go through this phased responsible reopening.
So a lot of our participants today have some underlying health issues, perhaps of a certain age. Could you lay out the guidelines for determining who should walk back through the doors of UH right now and who should maybe make a phone call first to see the appropriate way to move forward?
Well, first of all, everything starts with a relationship between the patient and the patient's physician. So that's the underlying tenet of our, if you will, game plan and how we are going to deal with our patients. We have some of the nation's top physicians. And so if there's any question or concern about whether you should walk through the door or have a televisit, those are the kind of questions that we would urge you to have with your physician. One of the things that I think we've become very clear about, and we don't want to, if you will, allow to continue, is that in some circumstances we have folks who may be a bit older, may have an underlying medical condition, but they themselves or their family members notice a deterioration, whether it be a diabetic situation, a heart situation, breathing situations. And in some circumstances, we've seen those folks self-deciding, if you will, not to come in. That's what we need to get away from. We really need to get away from that. We need to have those folks, those patients, interact with their physicians. And 9 times out of 10, if there is a change or some deterioration, my guess is their physician will recommend an in-person visit using all the latest precautionary techniques. If it is maybe a routine visit and there's some escalating risk, but no real escalation in the health condition, it may be very likely that the physician will recommend and say it's fine to have a virtual visit. Because as you know, we've had now, in the last few weeks, we've had 34,000 virtual visits. It's working very well. So I do think at the end of the day, it comes down to a conversation with the patient and their healthcare provider.
I would just add, Cliff, you know, I'm an emergency physician by clinical practice, and was even working this weekend. And I have to tell you, very alarming statistics. We've seen heart attack and stroke relatively vanish in our community, which suggests, as Cliff said, that patients aren't seeking care when they need it. And I share that with you not to scare, but really to help put the risk in context. And as Cliff described, it really is understanding that, in fact, if you have underlying health issues, you may be some of the types of patients who are particularly in need of getting in to see your doctor. So would encourage you all to reach out to your doctor and have that discussion so that they can best advise you in your circumstance.
You know, this might be a good opportunity to stay on that topic for just a minute, because in the beginning, I think that maybe people were confused about why we were asking them to stay home. It was never that it was dangerous to walk through the emergency department doors at UH. There was a separation actually from COVID and other, but it was about that PPE, right?
The fundamental driving force of, if you will, limiting patient access to the healthcare industry was to, at the beginning, was to limit PPE. It wasn't driven by an underlying fear that necessarily we have a hotbed of infection that is going to infect people, because the government knew that we would follow the necessary guidelines. You're absolutely correct, Maisie. The driving force at the beginning to limit access to healthcare was to preserve PPE for a significant surge of monumental proportions that did not happen here. We read about some of it in New York, and indeed those places really had to have and still have stopped all non-essential procedures. Thank goodness, I think we were ahead of the game here and we listened, and now we could get back to that essential and non-essential health care.
Yeah, that's a great question and a great point. Just building on what Cliff said, because we flattened the curve, we've built up a deep inventory of personal protective equipment. We have ample capacity. And really the data, the preliminary data suggests that your risk of any transmission inside of a UH facility and what we're finding with early pre-surgery and pre-procedural testing is virtually as close to zero as you can get. And so that data will mature and we'll continue to report our findings. But UH has always been safe, and in fact it's safer now than ever. And so that really is a misunderstanding, I think, as you described, Macy, that the real risk was about preserving capacity in terms of PPE and certainly inpatient beds. And we're very fortunate that's not the case.
I think some of our viewers are a little confused about the numbers. So if you could kind of walk us through that, especially when they started throwing in assumed numbers. So what are the latest death numbers? And do you feel they're inflated for any reason?
I'm happy to give you my opinion. I'm certainly not an epidemiologist by pedigree, but I spend a lot of time talking with our colleagues across the state and with the governor's office. And what we know today in Ohio, for example, is that we're just under 20,000 confirmed cases. Confirmed cases require a test to make that determination. And then we know that there's approximately 1,000 deaths, just a little bit over that. And so those are data we have a high degree of confidence in. Those are being reported on a daily basis. UH is part of the modeling efforts that are going into interpreting that data. We do know that we're not testing everyone we could, although over the coming weeks, we're going to be doubling and tripling our capacity here at UH as are others across the state. And that's going to allow us to test more people. We'll certainly learn more, but the general notion of risk is probably as we understand it today. And we have confidence around that because the sickest of the sick are the ones who come to our hospitals, those that are able to stay at home, who have mild disease or oftentimes exhibit no symptoms, are less the focus. The real focus, the real risk is around those who have a higher acuity illness when COVID is present. So the data is probably best understood as our data in Ohio is pretty sound. The national data requires a much broader infrastructure in terms of being able to understand the lag and reporting periods, et cetera. But we're very fortunate in Ohio. And again, a lot of that is thanks to all of you and our neighbors for taking aggressive action and being very thoughtful in terms of how we respect the best practices around hand hygiene, masking, et cetera. So I would say right now the numbers are probably pretty solid for Ohio. When we look more globally and certainly nationally, a lot more inputs there that we're going to learn more about over the coming weeks.
So it sounds like, let's talk antibody testing for just a moment. And first, could you just bring us up to date, the latest on the ability to do that? And then what is the criteria? Frontline workers first, but then our viewers, when would they be able to take advantage of that?
If you go.
Yeah, I'll start. So we're beginning a research protocol. This will be a study in which we're going to begin with an initial tranche of 10,000 tests. Those 10,000 tests will focus on clinicians and caregivers on the front line. Those are highest risk. Also our partners in care, first responders, et cetera. And the goal here is really to understand the antibody test. A lot of literature coming out from around the world in terms of different testing mechanics and methodologies, how to interpret those results. We do not plan to use the test at this point in time to really do any decision making, but it does help us start to understand the impact, the spread, particularly within the healthcare community. Our goal over time will be to expand antibody testing as the science and the research indicates more broadly in the community, and certainly in other countries we're seeing that as a valuable way to be able to really understand prevalence of disease across large populations, particularly those that are asymptomatic or those who may have had COVID and are now recovered. We don't know enough yet to know how much protection an antibody presence really means. There are various scenarios in which reinfection may be possible and or the potential longevity of that immunity. So early to say, but we're happy to report UH is on the front line conducting that research to help inform in a very thoughtful way how best to use antibody testing. So that'll be coming live here at UH later this week, and we'll continue to scale as evidence and the research protocol indicate.
There was some positive news over the weekend about remdesivir. Would you like to update us on that?
Sure. Remdesivir is a antiviral agent that is made by a company called Gilead, and we were very fortunate to be included as one of the first hospitals in the United States to participate in an FDA sponsored clinical trial to assess its ability to, if you will, lessen the injury to a human who is already been diagnosed with COVID, particularly patients who have been admitted to the hospital, who have a desaturation in their oxygen levels and may be heading to the intensive care unit before they become intubated, which is, as you know, kind of the last step along that pathway. And so we were very fortunate to be literally one of the first hospitals in the United States. Again, tremendous amount of credit for those who haven't been watching. We keep crediting Dr. Grace McComsey and Dr. Bob Salata, Dr. Ali Sadi, Dr. Keith Armitage, and that entire team and Claudia Hoyen, by the way, who created and got and made the FDA, and more importantly, Gilead, feel comfortable that UH could be a trustworthy steward of their very precious drug. Well, the good news is that the data now shows that when someone is given this drug who's already fairly sick with COVID, that it reduces the length of hospitalization fairly significantly from about 13 to 14 days down to 8 days. And it significantly reduces the potential death rate significantly. So therefore, the FDA has given emergency clearance for this drug now to be used in patients around the country who get admitted, not patients who have tested positive, who have minimal symptoms, who are sent home, not patients who are having a cough and aren't able to be managed as an outpatient, but for patients that are admitted, they've given emergency clearance for this drug now to be used. And this is a big deal. The reason why it's a big deal is heretofore we had no, if you will, armamentarium to fight this virus except the standard supportive measures. In other words, intubation, oxygen, and some old-fashioned steroids. Now we have something akin to Tamiflu, almost for the flu that you give to lessen the severity. It's a big deal. And as you know, Gilead over the weekend, I know on the Sunday morning talk shows, you saw the CEO, Mr. O'Day, was talking about ramping up the production so that this drug can be available all over the place. It's not a panacea, because at the end of the day, it's not going to stop COVID from happening, but it's a amazing, wonderful, I think, weapon that medicine has. And now UH is and was on the forefront, and certainly will continue to have that available. Dr. Beck?
Yeah, I would just add, you know, a little bit of the inside baseball there. Gilead was very generous. They donated about 1.5 million doses to FEMA, and FEMA will then just distribute those through a prioritization vehicle. At UH, because we were the first site as a trial partner, we actually have drug here for those that are possible, and different treatment protocols. So we're really happy to be supporting the community with drug on site. You know, the others will require some logistics to get those drugs to those who need it in a timely fashion. And we had some experience with that early on in the pandemic, but because of our just amazing team, as you heard, Dr. McCumsey and the entire infectious disease group, we're happy to be positioned here in Northeast Ohio with drug on site to enroll patients as appropriate in the trial. So it's wonderful.
So to be clear, and you correct me if I'm wrong, but because UH was one of the first in, we will continue to be able to offer it to our patients who need it through our own internal mechanism. For many other places, they will be required to work with FEMA to secure access to this. So again, it is something that UH had foresight in doing, and I think it will pay dividends to our patients.
Exactly right, Cliff. Exactly right. UH is perfectly positioned to make use of that for patients who are eligible and in need.
So Holly asks a question that's on the minds of a lot of people. She was out over the weekend, beautiful weekend, people all around her not wearing a mask. How can we expect to be safe when other people aren't being safe? And I'm going to throw another question in there. If this continues, would it be safe to say that we can expect a surge?
Well, you know, I was out this weekend too. I think, you know, I think that there's a couple different scenarios of people not wearing masks and why, and if that is an issue. So it was a beautiful weekend, and I was out too with my wife and my dogs, and people were walking. The new culture is you don't walk even 30 feet near another, I call them germ pods. So my family, when I'm walking, we don't, and I'm at home with my wife and my kids, we don't wear masks because we've kind of somehow, hopefully, created our own little biosystem. And when we walk, and we stay far away from people, and I'm not too worried if someone walks 30 feet away from me with their family without a mask. I think the concern is when people get very close together who are not, if you will, already a biological unit, whether that be in a sporting event or whether that be in a restaurant, and they're very close. That's what we have to get away from, and we really need to mask up in those situations. I learned, for example, as I visited a couple of establishments that were legally allowed to open, very clearly they say when you come in our store, you must wear a mask. So I agree with the caller, Holly, that if she was witnessing people in close proximity to each other, they should have been wearing a mask. But if they're out in walking and they're far distance from each other, I'm not sure, as long as the group is together and been together, that they have to. But that's my take on things.
Yeah, I would just add that it comes back to those fundamentals, right? So when you can engage in touchless activities, when you can maintain appropriate distance, when you can be mindful of the other basic premises like good hand hygiene, all of those things help to de-risk. But to the second part of the question, you know, the government is not naive. Having spoken with DeWine's administration on Friday, we are expecting some uptick. That will be part of the price we pay for continuing to keep the economy going, for getting people the necessary support that they need. A lot of members of our community are really in need of being able to get back to work, et cetera. And so those are very calculated decisions, and I agree with Cliff that we will see a spike up. The good news is we're better prepared. We can manage it. Where we're seeing the densest concentration of that activity, we're actually intervening proactively to contain the spread. And again, it'll rely on all of us and our Midwestern sensibilities to respect the best practices to minimize transmission.
Margaret has a couple of questions, the latest on chloroquine, and then also looking at Sweden, they chose not to lock things down there and things seem to go well. Any thoughts on that?
Well, I'll start with chloroquine. You know, there's a number of different disparate data sources. The fundamental issue with chloroquine is there was a hypothesis and some anecdotal evidence from one study in France that chloroquine or hydroxychloroquine, which for those who don't know is an anti-malarial agent that was first developed literally in the 30s by the Germans and used beginning in the early 50s as an anti-malarial agent, can have some, if you will, amelioration of the symptoms of COVID. There was a study that was not properly blinded, but was done out of France that suggested that it was helpful. And then it got a lot of press all throughout all the different press channels. There was then somewhat of a rush to chloroquine, and some people were injured from improper dosing based on some side effects of chloroquine. There is now, I think, and Eric can chime in, a feeling afoot that if someone is going to be using chloroquine who has the disease, that it should be done in a clinical trial where it's safely administered at the proper dosing. And these sort of clinical trials are really what I think Dr. Fauci has wanted for a long time. I think the scary part about chloroquine is when people somehow get a hold of it through other means, maybe not necessarily prescribed for that purpose, and then use it as a preventive agent, and then either improperly dose and or superdose it and wind up with some cardiac side effects from it. So I think we got to be careful, and we got to make sure that when it is used in a clinical trial, because when it's in a clinical trial, the dosing has been well thought out in advance, and there's tremendous surveillance to detect side effects before they happen. So I think that's the best news I have right now about it, and it still begs a clinical trial. I'm not ready to say it's something we should all be embracing. I'm ready to say that now, but remdesivir, because it's withstood a fairly rigorous clinical trial. But I do think there's some possible promise with chloroquine, hydroxychloroquine, but it needs some work.
Yeah, there's no silver bullet. It is a tool in the toolbox, and only, as Cliff has said, a physician probably in a research trial is going to be best able to help guide you there. Certainly, remdesivir has a much more promising and stronger evidence base to support its use. I think there was a second part of the question, Macy. I want to make sure we respond to that as well.
Sweden?
Oh, Sweden. Yeah. So we're all studying the experiences of those who've gone before us around the world, and even here in the United States, if they were on the front end, to understand which practices seem to really help to limit transmission and community spread during reopening. It's a complicated exercise because the practices that were employed by each of these individual communities also have a set of context around them in terms of what were the conditions on the ground, what was the spread of the virus sort of baseline prior to that. And so really trying to understand which of those make the most sense for us. I think that we should all be reassured that the governor and Dr. Acton have taken a very measured approach. It's really a phased approach to reopening. They're engaging with experts from industry to be able to define some of the best practices for those particular segments. All of that helps to reduce the risk. I don't think any two communities are going to be exactly the same.
All right.
You know, I think it begs mentioning, you know, I think the concern about Sweden and that exactly how much social distancing and was taken in place, it is a different environment. It's a fairly homogeneous population in terms of demographics. But it shouldn't come as a surprise that the experience in Sweden may be different than it was in Italy, and that is now different in the United States. If you just look at the United States, clearly the experience in Cleveland is a lot different than Detroit, which is 5 to 6 times more, even though we're very similar cities, only 180 miles apart. So there's clearly some factors that are economic factors, socioeconomic factors, demographic factors, health baseline data factors, as well as communication factors, and even issues with regard to social distancing of people's homes and how they live. And all those things play a role. So I think that may go and explain a little bit of what's different perhaps in Sweden than is different here.
In the beginning, the really, really sick got tested, and now there are a lot of tests, and there are a lot of different types of tests, the saliva, a couple of nasal. Could you give us some advice about getting an accurate test? And then what are the guidelines? Who needs to be tested today?
Well, all of the tests are rooted in common methodology. Some tests have a better sensitivity and specificity than others. Always best to seek testing under a doctor's care, a doctor's order. Some of the newer tests that are coming out hold great promise. Specimen collection, meaning how we get the sample to be tested, is a really important component of that. Some of the deeper nasal swabbings, for example, can be difficult to administer on yourself without experience. Some of the newer methodologies, including saliva, et cetera, show great promise, but I would say we're still early in the home testing environment. At UH, we enjoy rapid testing across all of our hospitals in the emergency department so that we can get timely results for people who need that. We also continue to expand and grow our ambulatory testing locations. Soon we'll have 10 across Northeast Ohio to continue to support people who, for example, need to seek a procedure that was postponed. The other piece I would say is understanding how that capacity scales. We're going to, as I mentioned, be tripling our capacity here over the coming weeks, and with state support, we may even quadruple that. And as we do, testing more people will allow us to provide testing under the assurance of the UH brand, as opposed to an organization that perhaps you don't have that connectivity with, you don't have that trusted relationship with, and that would be sort of the underlying advice. Turnaround time is the other big piece, and when you engage with some of these third-party firms, the turnaround times have been unfortunately lagging in many cases, and we're very proud of our turnaround times, same day, and when we do rapid testing in under an hour. So those are sort of the key ways to sort of think about testing in current state.
And I'll add one thing, I think, to give hopefully some comfort to the audience. Friday was the first day per governor's orders that we could begin doing non-essential procedures. That includes surgeries, and I myself was one of the surgeons who had patients that needed to have surgery. So that day we did close to 100% more surgeries than we did the day before on Thursday. You could worry, well, gosh, what if some of these folks who come in have COVID? Well, that's not going to happen because, for example, my patient came in the day before and had a test, that being a COVID test, was found to be indeed negative and was able to proceed, and all of us knew that patient was negative, and we were able to proceed without consuming an abnormal amount of PPE. Today, we're close to 300 patients throughout the system. And all these patients who come in for surgery are being tested, and isn't it great that our testing paradigm gives an answer that day, sometimes within half an hour. In fact, the Abbott machine gives the answer within 8 minutes. So we know if a patient's going to come in and if they're going to have COVID. If that is the case, and it's absolutely necessary, then we have special COVID rooms to do the surgery. If they don't need it that day, and they go and wait till the situation's better and they've recovered. So I want people to know that we're not just letting people come in for, if you will, high intensity procedures without knowing where they are. And as a result, we've been able to ramp up our testing paradigm to literally hundreds of tests a day. And I think that's going to behoove us in the future, and it's going to make people in the community feel pretty good about coming into UH.
Margaret brings up a good point. Yeah, best defense against the disease is a strong immunity. And what do you recommend to maintain a strong immunity, which involves exposure to germs? How can we navigate under this new sterile environment?
Well, let me just go back. I wish I could stand here today and say that we are aware of these 5 things that you could do to improve your own personal immunity, specifically to help ward off a COVID infection. And the answer is none of us have that information. Unfortunately, we don't have the ability, at least I don't, and neither does probably anyone in our system, to have intimate knowledge of what we can do to literally uptick or downtick our immune systems in rapid fashion. What we do know, again, going back, is how to prevent our, if you will, susceptibility to a COVID by virtue of distancing from non-family members who we haven't been around, by washing of our hands, by doing all the things that we've talked about. I think it would be probably unsafe and maybe even dangerous to give a false sense of security to our community and to our patients if we said or even thought that there was a particular trick we could do to uptick our immunity, and then people would have a false sense of security and then wind up getting sick. So unfortunately, we don't have information about that, and we historically haven't. And we've all heard the wives' tales, whether it be vitamin C and a good night's rest and all these things, which I think are important. But I don't believe that that will confer a, if you will, a supercharged immune system to prevent COVID right now.
Dr. Megerian, speaking of a false sense of security, families are wanting to see grandparents. Grandparents are wanting to see children. And maybe they're coming from 2 different quarantined areas, safe areas, together for the first time. Wouldn't this be the time to be more vigilant than ever? That doesn't necessarily mean that they're going to be safe, correct?
Yeah, I would say we want to be very cautious. And as Cliff said, it's about taking care of yourself. We know that much is always sort of, important to do. How much additional protection it provides. But again, the fundamentals around being particularly cautious regarding those that are older, those who have chronic conditions, those we want to be particularly careful with. Again, masking, distancing when and where it makes sense to have those encounters in a more compartmentalized way, lowering the number of interactions. We know that in some cases, children can be asymptomatic carriers of the virus. And so all things to be mindful of. But again, this isn't a black and white sort of scenario. It's really a continuum of risk. And you, in consultation with your healthcare provider, can have a conversation about your specific risk and how to put that in context.
So as we begin to wrap up, maybe this is an opportunity to tell people, after we have been asking them for quite a while to stay home and stay away and to do virtual health, we're now asking them to come in and get the needed care that is necessary. So maybe if we could wrap up with a message to them about how that is a safe option.
Yeah, we've done some work. We've looked into this, and I want, first of all, I think it's very important to reiterate one of the principal reasons by which both our health system as well as our state and federal government put a hold on what we call non-essential procedures. That was not done because there was a concern that the hospital itself is a hotbed for risk and for sickness from this virus. It was done because there was a legitimate concern that we were going to run out of PPE. So now that that's been taken off the table, at least in Ohio, we feel that we can judiciously reinvigorate the ability for patients to get non-essential procedures and to see their doctors, as long as we follow the necessary guidelines. The big things that I think that we know a patient is afraid of, and I think it's okay to be afraid. That's what keeps people in humans alive is to be afraid of some things. And what are the things that people are afraid of? Number one, they're afraid that when they come to the hospital or the doctor's office, that they will be infected by other patients. We feel very confident by using the playbook, as we call it, the necessary distancing, the proper distancing in the waiting rooms, the use of masks, the hand washing, and more importantly, the sanitizing of the various tabletops, that we will minimize that. The next thing is that patients need to know that their doctors recommend it. So if there's any question, I think, again, we go back to the tenet that UH is also and always has been built into the concept that it's the relationship between the patient and their doctor. So if there's any questions about whether you should be coming in, that's something you discuss with your doctor. But we want to make it abundantly clear that we're here for you, we're safe, we're going to take care of you, as we have for the last 53 years. Eric?
I would just say, certainly there are some who have high risk, and we can take additional precautions. Your provider's best positioned to help answer those questions. I'd just like to express my thanks to all of you for your continued support and encouragement, and we stand ready to support you as we responsibly restart Ohio.
You know, I can't thank you enough. I mean, the outpouring of support for our caregivers in our hospital has been absolutely amazing. I know there'll be a slide put up at the end that will, if you will, describe ways to help us. Those dollars, for example, that have been given, both dollars and food, have been used to help. For example, some of those dollars are supporting our clinical trial and antibody testing. Some of those dollars are used to help buy necessary equipment. It's amazing what you've been able to do. And then with regards to the ability to support our caregivers with food, where sometimes it's hard to get it, you've been absolutely amazing. So I'd like to really do two things, if it's okay. Number one, make sure you understand how thankful I am, Eric is, and all of us in senior leadership are, for your guidance, your questions, your advice, and your trust, because that's really the most important thing that we have to offer right now. I'd like to replay, if possible, for those who joined late, our public service announcement. I don't know if it's possible, Kim, to play the longer version, or we'll play the version that went on at the beginning. And then following that, we'll have a slide which describes ways to help UH if that's something you want to do. So with that being said, thank you very much. Stay safe. We hope to see more of you in person.
Thank you.
Thank you. You stayed home. You flattened the curve so hospitals weren't overwhelmed. You took care of us. Now it's time for us to get back to taking care of you. University Hospitals is following CDC guidelines and all of the governor's recommendations to ensure your safety. Your healthcare needs haven't gone away, and there's a risk to ignoring them. We are here to safely provide you with the care you need.